Hey, hello, I'm Ari Yagunidis. I'm head of Department of Hematology, Oncology and Palliative Care in St. Mary's Hospital Düsseldorf in Germany. I'm going to talk to you today about myelodysplastic syndromes, epidemiology, treatment possibilities, prognosis, and new developments in the last couple of years, and I hope you find this interesting.
If you forget everything about myelodysplastic syndromes during your studies, at least try and remember this one single slide that I'm showing you here, which is the definition of the disease. Myelodysplastic syndromes are hematopoietic stem cell disorders. These are neoplastic diseases of the bone marrow, and that means that these diseases can evolve to acute leukemia and actually kill the patient. There are two subtypes of MDS. There is early MDS and late stage MDS. The early MDS has primarily the problem that the cells in the bone marrow suffer from increased apoptosis. So you do have a full bone marrow, although you have cytopenia in the peripheral blood. And the full bone marrow actually is unable to differentiate to cells that would be seen in the peripheral blood and function as they are required. And therefore, with the apoptosis in the bone marrow, what happens is that the full bone marrow actually contrasts to the peripheral cytopenia. The cells in the bone marrow are unable to differentiate to normal cells. They die in the bone marrow, and that is called intramedullary apoptosis of cells, which is a hallmark of MDS. In later stages, however, with accumulation of genetic abnormalities, the cells acquire proliferative advantage. And what you see in later stages of myelodysplastic syndromes is an increase in blast cells. And therefore, the disease is being pushed toward acute leukemia. So you have a blast count that increases over 5%, 10%, maybe 20%, and you know that the threshold to the diagnosis of acute myeloid leukemia is 20%. So when you reach 20% and above, you are already talking about acute myeloid leukemia. Myelodysplastic syndrome patients have, if they have advanced MDS, blast counts of 5 to 20%. So again, to recapitulate, early MDS, apoptotic, intramedullary death of the cells, later stage accumulation of blasts, and then switch to acute myeloid leukemia. But this is not enough. The hallmark of the disease is actually dysplasia in the bone marrow. So what you see when you look at the smear of an MDS patient is a lot of dysplastic features, and we are going to look through some of the dysplastic features in a minute. And I'm going to explain to you what you can expect in a bone marrow of an MDS patient. Now, as you can see here on this slide, MDS are very heterogeneous. As a matter of fact, you can see that 20% of your patient have a relatively bad prognosis and may die within only a few months of their diagnosis. But then you have another 20% of patients who live for more than 6 years. So you need powerful prognostication to be able to tell a patient whether his disease is rather long-lasting or whether the disease is bound to develop early to a very aggressive hematopoietic neoplasm, and then obviously your treatment should be more aggressive also. If we are talking about incidence of myelodysplastic syndrome patients, this increases with higher age. It's rare, not impossible, but pretty rare to have MDS patients below the age of 50 years. Now, above the age of 60, it becomes somewhat more frequent, and at the age of 70 to 80 or above 80 is actually one of the most prominent myeloid diseases in human beings. Causative agents? Well, I think all you have to remember here is that benzene can actually lead to myelodysplastic syndromes, and what is important is that you recognize that cigarette smoke actually contains quite a bit of benzene. It's about 100 micrograms of benzene in every cigarette, and therefore smoking cigarettes does actually increase the probability of myelodysplastic syndromes. Also, X-rays, occupational exposure to X-rays, or radiation may increase the risk of myelodysplastic syndromes, and previous chemotherapy with alkylating agents or topoisomerase inhibitors may increase the risk of myelodysplastic syndromes. Problem with MDS is that you see a patient with peripheral cytopenias, and unless you have done a bone marrow, which is obviously showing you severe dysplasia, and you can actually tell the patient that it's myelodysplastic syndromes, sometimes can be actually pretty tricky to make the diagnosis, because there is a large plethora of differential diagnoses. It could be toxic problems of the bone marrow because of drugs or because of other influences on your bone marrow. It could be infectious diseases that actually also lead to some kind of dysplastic abnormality. Your bone marrow can show immune cytopenias, isolated or combined immune cytopenias, acquired immune neutrophilia plus acquired immune thrombocytopenia, for instance. You could have megaloblastic anemia, which usually goes along with a very high LDH, but I mean, if you don't think about it, you see peripheral cytopenias, and you may think, and if you do a bone marrow, actually, you see pretty dysplastic erythropoiesis. So if you don't take care to actually look at the cells very carefully, do a vitamin B12 and folic acid in the peripheral blood, then you might actually be misled and call a megaloblastic anemia a myelodysplastic syndrome. And then other problems like hypersplenism, anemia of chronic disease, or paroxysmal nocturnal hemoglobinuria could be differential diagnosis of MDS. So a difficult disease to diagnose, and you really need to look into it to make a solid and valid diagnosis. So let's talk about the prerequisites for the diagnosis of MDS, and that is a good bone marrow. And that means you need a high quality smear that is made on fresh bone marrow and peripheral blood with an excellent staining, and count enough cells in the bone marrow, because if you don't count enough cells, then the blast count can vary actually very dramatically, and you might actually end up with a false count and therefore a false diagnosis. Here we see a couple of pictures from MDS bone marrows, and obviously these are relatively straightforward cases. What you see is, for instance, erythroid dysplasia here and there and here, what is called karyorrhexis. But you also see hypogranularity, for instance, of this promyelocyte. And this is also a dysplastic sign of hematopoiesis. Here you see what we call internuclear bridging, but also, as you can recognize on this and on that side you have hypogranular granulopoiesis. Finally, the hyposegmentation of granulocytic cells in the peripheral blood or in the bone marrow may be relatively prominent. This is a pseudopelga cell. This, in contrast, is an eosinophil. So don't confound the eosinophils with the pseudopelgas. These here on the right side of the panel are so-called homozygous pseudopelgas because they can't even segment into two segments. They remain mostly in one segment, although they are absolutely finally differentiated and should be multi-segmented neutrophils. On the left side here, you see a myeloperoxidase stain, and myeloperoxidase usually has a dark brown staining in the cytoplasm, but as you can see, some of the myeloid cells are actually not stained, and therefore this is what we call partial myeloperoxidase deficiency, one important sign of dysplasia in the bone marrow. And then on the right side, you see on the one hand a dysplastic erythroid cell, but on the other hand something that we call abnormal chromatin clumping, which is very often seen in p53 mutated cases. Here, two examples of dysplastic megakaryocytes. On the left side, you have a cell with isolated nuclei, which is atypical for megakaryocytes. This would be a dysplastic megakaryocyte. On the right hand, you have the typical megakaryocytes of so-called 5q- syndrome. These are medium-sized megakaryocytes that have one nucleus, and this one nucleus is usually eccentric and hypolobulated. The other important feature of myelodysplastic syndrome is that they have that 50% of them have cytogenetic abnormalities. And they obviously can help you to make the diagnosis, because if you find typical cytogenetic abnormalities of MDS and you have dysplastic features in the bone marrow, the diagnosis is much easier than if you have a normal karyotype, obviously. Now, you don't need a lot of bone marrow to do a good cytogenetic analysis of it. These are living cells. Send them with express mail to the cytogenetic lab that you use. And one important thing is that you have to have enough metaphases that have been analyzed, because if you have only few metaphases analyzed, you might miss some of the typical cytogenetic abnormalities in MDS. I talked about prognosis earlier, and if you want to tell the patient how his disease is going to evolve, you need powerful tools. And one of those powerful tools is the International Prognostic Scoring System, which has been revised in 2012 and been presented by an international group. And what this IPSS revised includes is the bone marrow blast count, because this is an important feature of myelodysplastic syndromes. We talked about that. The cytogenetics, which I have talked quite a bit about a minute ago, and then the peripheral cytopenias, including hemoglobin, white blood cell count, and absolute neutrophil count, and the platelets. And as you can see, these different factors are weighed in different ways. So the cytogenetics get a relatively high ranking, with intermediate cytogenetics giving you 2 points, poor cytogenetics 3 points, and very poor cytogenetics 4 points. So actually cytogenetics are weighed relatively strongly in the IPSSR. Now, the blast count also is weighed relatively strongly, because once you have 5 to 10 or more than 10% blast, you get a high score assigned, and therefore the risk of the patient increases. Finally, you see that the peripheral blood counts, hemoglobin, ANC, and platelets also weigh in, but not as profoundly as cytogenetics and blasts. If you put all this together, you get different risks. You get a very low risk, a low risk, intermediate, high, and very high risk. And the score is easy to remember. Below 1.5 is very low risk, and then afterwards it increases actually by 1.5 points. So you have below 1.5, then 1.5 to 3, then 3.5 to 4.5, then you have 5 to 6, and then above 6. And you see that the survival is actually strongly different, and the very high risk group actually has a survival of just 1 year, while the very low risk group has a survival of 8.2 years. Remember that those patients have a median age of diagnosis of 70 to 72 years, and therefore this survival in the very low risk group actually mimics the survival of the normal population of westernized countries. Now, we've talked about the cytogenetics, but you're going to ask me, okay, you told us that the good risk and the very good risk cytogenetic and the intermediate risk of cytogenetics, etc., is assigned a certain point value, but what are those cytogenetic subgroups? And you see them here. The very good subgroup, for instance, is -Y or deletion 11q. Very poor subgroup is a complex karyotype with more than 3 abnormalities. And a poor risk cytogenetic abnormality would be a complex karyotype with 3 abnormalities or double abnormalities including -7, 7q-, or derivatives of chromosome 3. So I think it goes to show that complex karyotypic abnormalities have actually a poor cytogenetic risk and therefore also a poor overall risk. Importantly, good risk is a normal karyotype or a del5q, del12p, del20q. I think it's worth memorizing those, and then intermediate is going to be everything else. Now, it's not only cytogenetic abnormality that count. Also, mutated genes, single gene mutations have been shown to exist in a very high percentage actually of myelodysplastic syndromes, and the most important ones are shown here, with p53 leading the crowd. As you know, p53 is a gene that, if mutated, confers a very bad prognosis to many of the tumors, solid tumors and hematopoietic tumors, and therefore obviously is going to be first on the cards also in myelodysplastic syndromes. But then you see that AXL1, EZH2, RAS, RUNX, TET2, IDH2, SF3B1 and other mutations, this is not an exhaustive list, and other mutations actually are very important in myelodysplastic syndromes too. And when you look at it, actually look at ASXL1 for instance, it has a lot of ramifications and can occur together with TNM3 mutations and with EZH2 mutations, FLT3 mutations, or spliceosome mutations. Same thing is true for TET2, which is relatively frequently mutated in myelodysplastic syndromes and may be co-mutated with spliceosome mutations or other mutations, as you can see, including p53. Now, say you have a patient with a normal karyotype and the patient actually shows a mutation or several mutations. What does that mean? So you have a normal karyotype, which we have seen in the IPSSR would be a good risk cytogenetic abnormality, or is actually not an abnormality, okay? Good risk would be a good risk. So in the cytogenetic score would get you only a very low scoring point, but you have several driver mutations. Now, as you can see, if you have 0, 1, or 2 driver mutations, essentially the prognosis remains more or less in a narrow band. However, if you have 3, 4, 5, or more than 6 mutations, you see that the prognosis actually becomes very bad indeed. So a lot of mutations confers bad prognosis, and I think this is important to know, and I think it's important to remember this graph, which goes to show that the more mutations you have in myelodysplastic syndromes, the worse the outcome is. The WHO has classified the myelodysplastic syndromes, and there is a new classification which has come out in 2016, and I invite you to have a look at this. Now, it may look a little bit complicated. It's actually on 3 different slides here. And what I want to say is that all you have to remember, really, if you're not an expert in myelodysplastic syndromes, is that you have early and advanced MDS. And the early myelodysplastic syndromes all share one important feature, and that is a bone marrow blast count of less than 5% and a peripheral blast count of less than 1%. And they are shown here. The early MDS have the low blast counts, as you can see here, and they have unilineage dysplasia, single lineage dysplasia, or multilineage dysplasia. And they may have ring sideroblasts in the bone marrow, or they may not have ring sideroblasts in the bone marrow. And finally, you have MDS with isolated del5Q, which also is a feature of lower risk myelodysplastic syndromes, so not advanced MDS, if the bone marrow blast count is below 5%, if the peripheral blood count is less than 1%, and it's actually a misnomer because they call it MDS with isolated del5Q, but look, they actually accept one additional chromosomal abnormality, could be del5Q alone or with one additional abnormality, as long as it's not -7 or deletion 7q. Finally, you have the more advanced MDS, and they are called MDS with excess blasts. Excess blast 1 up to 10%, excess blast 2 exceeding 10% up to 20%, because at 20, as I said previously, is the threshold for acute myeloid leukemia. And then obviously there are certain special subgroups which are called MDS unclassifiable. For instance, you have a peripheral blood count which is not below 1%. It's exactly 1%, and you do this on several occasions, and you find several times in a row you find a peripheral blast count of just 1%. So it's called MDS unclassifiable with 1% blood blasts, but below 5% in the bone marrow. And then, how do you call that? Well, you call that MDS unclassifiable with 1% blood blast. Now, you may have single lineage dysplasia, but you have pancytopenia, severe pancytopenia, but still you have bone marrow blast count and peripheral blast count of less than 1%, and then you call this also MDS unclassifiable. I'm not going to spend too much time on those. If you have one of those patients, then you come back to this classification, which has been published in Blood in 2016. You look up the unclassifiable MDS and you make up your mind.